that they can hear some of these answers that they're so desperately waiting to hear. So with that, I believe that Senator Reagan Mikki Stier is going to start with some opening comments.
Good afternoon. Again, we're very honored that you've invited the Department of Human Services and our managed care partners to come to you today and talk to you about readiness, and that we will be ready April 1st. I would like to defer the time to those questions that you have, and we'll turn it over now to the MCOs so you can start your questioning. Thank you.
And with that, Senator Reagan will go first.
Thank you for being here. We really appreciate you taking the time to answer our questions. We've certainly had our share of questions from people out in the field. So this one I think actually starts with Director Stier. Informational letter number 1619 MC went out to many of the providers talking about crossover claims. And we all knew this was going to happen. We thought it was going to happen December 31st. And when we did changes to coding last fall, everybody had a time, they were practices, I don't know what you'd call them, but they had set up a system. So when it happened, it happened. You didn't have a choice. You had to get into the trial, and you looking at, for the first 90 days, that it is the way it is here with the crossover claims having to do the not being paid for the first, well, they'll have to wait for payment at least on the first 90 days.
So crossover claims, for those of you who don't know, are those individuals that have both Medicare and Medicaid, hence the word crossover, because they will be paid by two providers. A CMS regulation for crossover claims is that what you were using, Senator Reagan, was testing environment of testing claims. We can test claims. CMS requires us to have 3 months or 90 days of actual claims by MCO in order to process those crossover claims. Providers will continue to get paid, but what they'll do is their claim, like that informational letter explained, will come in, and then we will then manually process those claims, so we have that data that we can submit to CMS for the approval to electronically move towards crossover claims. And it's in the Medicare side of the CMS arm that requires us to have those claims for 3 months of testing, as they call it, live testing, rather than the practice testing that Senator Reagan was referring to.
So when it says it will be the provider's responsibility to submit the crossover claim to the appropriate MCO for reimbursement, what part of that is?
So they will submit the claim
To you, to IME.
Right.
First.
Yeah, and then we'll handle that portion of that claim.
Okay.
Okay.
And we were going to do this in December as well, if it would have happened?
Yes, because it's a CMS requirement to have actual claims versus tested claims.
Thank you. I'll let someone else have the next question.
I do have a question. This is from a substance abuse provider. Providers say that they won't know until April 1st which MCO individuals are assigned to, and after the transition, the list is only updated once per month. This delayed exchange of information may have a significant negative impact for services. Providers will need a current release signed by each Medicaid member to their MCO for exchange of information and for billing. Is there any way to make this update more than once a month for some of the providers?
I'll answer the state part. And so what we have done is our IT system, we do give the updated eligibility files at the end of the system. But however, we are today passing updated files to the MCOs on eligibility and changes in eligibility. Almost on a daily basis, we're changing and exchanging a file. So that's how it will be updated going forward, is giving more current information to the MCOs on a day-to-day basis with the file that we transfer daily. But the full file of all eligibility will continue to be at the end of the month. Okay?
So what happens is we do get those daily files from DHS and we load those. So anybody who's adding throughout the month is updated every day in the files. So it's only new people that aren't eligible until the next month that we get at the end. So the provider will be able to check on a daily basis.
And then I just have one very broad question. So this transition's taking place on April 1st. Everyone has a medical record. So can you explain to me how you're going to be able to, on April 1st, handle all of those medical records? Or how have you folded them in and still not violated any HIPAA?
I can start, that's okay. So what's happening with, for example, the waiver members, they have what's known as a service plan that's in place, and that's really what authorizes their services. That's the process that's in place today. And that process will continue to be in place in the future. And we are getting those service plans in advance of April 1st, but close to, so that it's the most current record available. So all of that will be loaded in our systems, and we'll have all of that information readily available to us by or before April 1st. The other medical records, we don't really get other medical records. We start accumulating that on April 1st.
Okay, so there's not going to be this big data drop at the end of the month where it's just going to be, it's going to be hard to sort through, so it's going to be folding
The
in.
process for the service plan transfer has been well worked out and tested, and it's really just getting the most recent information now.
All right, okay. In terms of billing, so providers have 3 managed care organizations, and they're going to be billing all of you for these services. How will that work? Will they have different pieces of software? Will they do one standardized form? What will that look like for providers who have limited resources, don't have billing specialists in many ways, and don't have the money to buy the software? What will that look like?
So I can try that one. So I think we're very sensitive to that, and especially for providers that don't have a more sophisticated system piece. So I think I can speak probably for all of us. It is the intensity of that connection piece. It is working with those on an outreach basis by the MCOs to those providers to ensure that we're working with them. We're very sensitive, especially to the community providers and the waiver providers, to ensure that we are connective to them and they understand who to call. They understand. We've gone through extensive trainings on you know, how to do the billing forms and how to work through that with us. But if there are issues, there are means for them to connect back in. It could be through the provider call center, which sometimes isn't as satisfactory as having someone who's right there with them. Maybe it's going out again and again to work through those forms, those processes with those providers to ensure that they know how to do what they need to do.
Are we talking about paper forms for quite a few weeks? So there's no digitized form. Is it paper forms that they have to fill out and send in?
So one of the things, prior to even the transition, Medicaid had multiple providers. You could have been Meridian, Magellan, Medicaid, Hawkeye. So some of our providers are very used to having multiple vendors for services for Medicaid members. One of the things that we have done with the plans, and there'll be an IL on this shortly or an informational letter on that, is that a lot of providers are used to the $1,500 billing for inpatient and UVs for the outpatient services, as well as the state has a waiver form or billing form. Consistently amongst all 4 of us, we will be using the same forms. That will not change. So to help with the learning curve and understanding, the forms will be the same as what we are using today in IME across those plans. So that will also help with our providers getting used to how to bill. In addition to that, we're working on what's called clearinghouses, that there will be, and these, I will defer this to them, that they can talk to the clearinghouse and how that will work for billing as well. So again, what we're working on or have been working on is the administrative simplification with the current forms that are used. And two of those forms, the UB92 and the 1500, are national billing forms. So keeping those in this process will add a smoother transition to billing, but I'll defer that to you guys.
I would agree with what Director Stier has indicated. These are standard billing forms, and we are working with providers, as my colleagues have indicated here, extensive training where there's questions. We want to work with those providers to ensure that they have their questions answered. The standardized billing forms, the ways in which they can bill us electronically. Those that aren't billing electronically, we're helping them to establish electronic billing if that is a choice that they want to make. And so the goal is to ensure that providers do have those questions answered, they understand how to bill us, and if not, we're going to help them in order to do that.
Any other questions? Senator Bolcom?
Thank you, Madam Chair. Thanks for being here. I feel like this is a bit of a shotgun wedding for some of us, but we're happy to have you and be able to talk directly with you. Two of the big issues that CMS had in their delay was network adequacy and whether or not case managers would be assigned. So I've got a couple questions. One is on case management. And I guess to our three MCO participants, do you feel like that case managers have been adequately assigned, that people have case managers? It's one of the things we've heard most from our constituents, concerned about losing their case manager. And I guess the question is, will you be using existing case managers, or do you anticipate that you'll, at least for 6 months, do that and replace those people with your own case management, or are you going to do a mix of that? And what kind of training are your case managers going through to make sure that they know what they're doing?
So we feel like the case managers are very prepared. In our case, we have 100% of the agencies that are going to continue to provide case management services contracted. Every single case manager that is an employee, which is a small percentage of the case managers in our case, and including the case managers that work for agencies that we're contracted with, have all been trained thoroughly. They've been through system training, they've been through process training. That continues to happen. We have assigned every member that we have to a case manager. If that case manager was still available through an agency or as an employee of ours, that member is still with the case manager they are with today. In the event that case manager has left and is no longer available, obviously we've had to reassign members. So in any situation where the case manager is available to us, the member keeps that case manager, because we believe that continuity of case management is very important, because that's a very key role for these members. And we want to make sure that there's someone who's as familiar as possible with the service plan in place for the member.
And I'll add that that's true beyond, you asked about the 6 months, that's true beyond the 6 months as well. And we also have all the case management entities that are with us, and of course there's a prescribed period of time for 6 months. But that also, so we will more than likely continue those processes with those case management agencies beyond that. So there's no magic cliff of beyond that 6 months. I think that's an opportunity for us to work through that transition, ensure the care is consistent, and we have every motivation to do that. And then, you know, having worked then with the case management agencies in this period of time, all 70 of them, it gives us a chance to understand them, they understand us, and but I also then agree that the training has been absolutely extensive, and we very much feel we are, in fact, we're chomping at the bit, you might say. They're ready.
Is training in-person training, or is it on the web? What is the training?
It's a variety of pieces. We're trying to figure out if we can speak for each other, but I think we're pretty consistent on that. I think it's a variety. It is web-based. It is direct. It is sometimes in meetings, sometimes with IME meetings. So there's been a variety of opportunity and a variety of ways to get at it. And sometimes people learn differently. So sometimes it's in person, sometimes it's electronically. So basically, if we get a request for any kind of training, we will honor that request. We will meet them where they want to be. We'll go out to wherever they are. So I feel like this is because it's one of the essence of managed care, and is the case management coordination component. So we will do whatever it takes to ensure that consistency in care management.
Thanks. The other question I had was network adequacy.